I'm Dr. Yuval Wagner, and I would like to present this paper on behalf of my colleagues from Israel and the US, named HLH Syndrome in a Community Hospital, the Challenge of Early Diagnosis. Hemophagocytic lymphocytosis is a rare disorder. HLH presents in two forms, one familial genetic and the other one secondary, most commonly to infection, but malignancies, autoimmune diseases, and other diseases can also cause HLH. Busy emergency room in a community hospital would see a multitude of children with infections. Unfortunately, if HLH complication will be missed, these patients may die. The Histocyte Society developed criteria to identify HLH for clinical studies termed HLH 2004 criteria. These criteria became widely accepted, but unfortunately, patients may die from HLH before fulfilling required 5 out of 8 criteria. These criteria may result in overdiagnosis, leading to unnecessary testing and overtreatment. Results. In almost 104,000 children evaluated in the Pediatric Emergency Department at Mayo Hospital between the years 2014 to 2017, 9 patients presented with prolonged fevers, cytopenias, and elevated soluble IL-2 receptors. All 9 patients had 5 or more of the 8 criteria fulfilling the 2004 criteria. 8 of the 9 had elevated ferritin levels. Median age was 1.1 years, and even though young children with HLH more likely to have genetic HLH, only 3 of the 9 had a genetic evaluation. At the time, genetic panels for HLH were hard to come by, explaining the low numbers. Only 1 had variants of uncertain significant genetics in UNC13D and STX-BP2. 1 patient died from Pseudomonas sepsis, but the initiating trigger was unknown. The other 8 had adenovirus, HV6, EBV, and strep group A as assumed triggers for HLH. HLH 2004 therapy that combines dexamethasone, etiposide, and cyclosporine A was used in 2 patients, but the other received a combination of dexamethasone, IVIG, with rapid response. Fever resolved in a median 2 days. Community clinics' health records allowed for long follow-up, noting 8 of the 9 long-term survivors with a median of 7 years. None had reactivation of HLH. Temporary evaluation of HLH include the CD107A degranulation test, perforin and granzyme expression, cytokine evaluation, specifically CXCL9 and IL-18, activated T cells, and specifically the elevation of CD38 HLA-DR CD8 cells should be evaluated. None of these studies were available to us at the time. Genetic panels rapidly identify genetic HLH can be accomplished in the United States within 48 hours. These would have probably been completed for most of our patients, if not all of them. In summary, 9 patients had at least 5 out of 8 HLH 2004 criteria. At least 8 of the 9 had infection triggers of HLH. 11% death, possibly secondary to delayed diagnosis or complication of HLH therapy, suggests that this disorder should be on the radar screen of every pediatric emergency evaluation. The addition of ferritin fibrinogen levels to the evaluation of prolonged fever may allow for early suggestion of HLH. Non-chemotherapy intervention with dexamethasone or IVIG may stabilize the patient to allow immediate transfer to a tertiary hospital where confirmatory testing can be done. Cytokine storms, including HLH or mast cell activation syndrome, can be targeted with cytokines inhibitors such as Anakinra and Gamifant, Emapalumab,